You've got host disabled.
Oh, have I done that again? Sorry. Should be all right now.
Can you see that?
Yes, lovely.
Okay, thanks, Siobhan. Yeah, so as Siobhan said, I'm an ST3. I've been hanging around the bazaars a little while, but wanted to get involved with this because it seems to be a bit of a growth area. Certainly has been for me in my consultations of late. So just about the scope of the problem, obviously menopause can affect half of us, half the population, and currently that equates to 4.3 million women working age. And this schematic just shows us sort of the scope of how much it's impacting. Roughly half saying that work can be a struggle, and up to a third of women say they don't feel like they're good company once they're going through the menopause. How tragic is that? And for 50%, it can be absolutely ruinous for their sex lives and relationships. So it's as we well understand in GP land, it's a huge issue, and it's something we are well equipped to tackle if done correctly. Obviously, this lady may have has featured very heavily, and menopause is nothing if not topical at the moment. I've certainly seen my menopause consult sort of probably double, I'd say, and it's a huge amount to cover safely within a 10-minute window. And obviously there's a huge amount of rumour dispelling to be done, given the legacy fear that those studies from the 90s and early 2000s, the impact of those studies had for women and their fear of breast cancer if they take HRT. So that's a little bit what we wanted to tackle today, and it's certainly something I find I'm often having to unpick with women. So that's a very wordy statement, but essentially, have a quick read. I won't read it out to you. Hold on, this is covering up my slide. That's the British Menopause Society's consensus statement, essentially saying it's a green light. Have a risk-benefit discussion with women, but there should be no excess risk for a woman with normal background risk of breast cancer in them choosing to take HRT. So let's look a bit, consider it in context. And I think this is the key for when you're talking to women, or certainly I found that it's key, is placing the risk of breast cancer in context with their other risk factors. And certainly a lot of them are modifiable. And I think having this wider conversation really gives a quantitative feel to them appreciating their personal risk of breast cancer. So over 5 years, women in that key age group, menopausal age group, 50 to 59, of 1,000 women, approximately 23 on the background population will get breast cancer. Now, second line down, if you take HRT, that risk increases by 4 people per 1,000 over that 5-year period. And I think the comparison I always like to draw out with women, and I don't think many women are aware of this, is that actually if you look at the obesity rates, then that risk of breast cancer for that background individual low risk person, it doubles if their BMI is 30 or over. So that is a modifiable risk factor, as is smoking, where it's an increase in 3 people. And the other very easily modifiable one is alcohol intake. So 2 or more units a day, that's a large glass of wine a day, and you are conferring a bigger risk of getting breast cancer than if you took HRT. And NICE are using background population risk as women who have got a first-degree relative who is greater than 40 years old at diagnosis. There's lots of other smaller in the weeds, but that's when you're talking to your average Joe population using 40 as the cutoff. So consultations are obviously focused around quality of life, and we know that menopause can have a huge impact on the quality of life of women in terms of their capacity to work, their capacity to think, their capacity to exercise, their capacity to lose weight, increase migraines, etc., etc. And we balance the conversation around the benefits of HRT, and they are numerous. And I know we're going to go on to talk at length about osteoporosis and heart disease, and so that the consultation must be balanced in terms of explaining the risks and the benefits. So looking at some of the data, this table here is taken from the Menopause Society, and they've collated all the data from three studies, but the two biggest ones being the Women's Health Initiative, the rehash of the data in 2020, and the collaborative group hormonal factors in breast cancer. And if you look at the data here, I don't know if you can see my cursor moving, but here's the background risk of those 1,000 women aged 50 to 59. 13 of us will be diagnosed with breast cancer without taking HRT. Now, in the up to 5 years use, estrogen only, according to the Women's Health Study Initiative, they found that there was a decrease in risk. But even if you look at the other studies, there's not a huge increase in absolute excess risk of breast cancer. This rises a little bit if you take it for 10 years, but it's not a huge difference when we're just considering absolute excess risk. And then that's just with estrogen alone. But if you look at the combined products, so the estrogens and the progesterone, again, it's not a huge increase. And that's where that pictographic comes in, the increase. If you take HRT, 3 to 4 extra people will get a breast cancer if they take a combined HRT. And obviously then the data becomes a little bit more worrying if you are taking it for over a 10-year period, and we'll go on to look at this in a bit more detail. So duration of use, WHI reported a small increase in the risk of breast cancer with combined preparations, which begins to emerge after the 3 years of exposure. So based on this data, women who are in the 50 to 90 menopausal age range, it's estimated that using the combined products for 5 years probably counts for an extra 3 cases per 1,000 women exposed. The estrogen-only arm, as I said, has a lower absolute risk of breast cancer, but this in the WHI study wasn't considered statistically significant when compared with placebo. So I think there's still a body of work to do. Smaller studies have shown that estrogen alone does confer a benefit compared to the combined products. And certainly I can remember a gynecologist teaching us, said that he was quite long in the tooth, but the best birthday present he could get his wife, who had turned 50, was a hysterectomy and some transdermal estrogen. So I guess he was talking about that. Going on to, where are we? Risks after cessation. Well, the data that I've looked at isn't absolutely clear. There's some confusion between, well, not confusion, just disagreement between the various studies. So the collaborative study done in 2019 showed that past users of HRT reported to have an increased risk of breast cancer diagnosis 10 years after cessation. However, all the evidence before this would suggest that there in fact was a fall in breast cancer diagnosis once you'd stopped your HRT. And certainly this latest 2020 WHI study would agree with that. And they did a median follow-up at 16 and 18.9 years for women allocated unopposed and combined HRT respectively. And basically they said that there was no increased risk post-cessation. And NICE very vaguely just summarizes this as the risk is duration dependent and falls after stopping. So again, that merits a conversation between the woman and what risk factors she has as an individual as to how long you pursue the HRT for her. Considering then whether the risks of breast cancer between continuous and sequential, again, there seems to be a duration dependent increased risk of breast cancer, which is higher with the continuous preparations, but the absolute risk is still very small. And you've got to balance this with the fact that actually the continuous preparations confer a benefit in terms of endometrial cancer risk, because they're providing continuous progestogenic dampening of that estrogenic effect, which causes the proliferation of the uterus. So again, it's a risk balance conversation with the woman. Microdosed, I think I've gone a bit over, haven't I not? Microdosed progesterone is obviously the what a lot of us are prescribing now, and essentially, briefly put, that we think that these newer progestogens, so we talk about the dihydrogestogen and the microdosed progesterone, have a less androgenic, oh goodness, that was difficult, proliferative effect. So the theory is that, and there's only data really from a study that I read, which had drawn all the data together, meta-analysis, up to 5 years. So I certainly, when I listen to Dr. Newson, she's dishing it out for life. From what I understand, there's very clear evidence out to 5 years, but not beyond that for micronized progesterone. And I think it's an area that's currently being studied, because I think the hope is that there will be a benefit conferred in decreasing breast cancer risk if we prescribe those newer progestogens rather than the old synthetic types. But putting the risk in perspective, I guess when we're talking to women, postmenopausal deaths in England and Wales from heart disease and osteoporosis far outnumber those of breast cancer. So when we're talking about the benefits of potentially that the HRT confers on bone health, on mental health, on physical health, on cardiovascular health, then there certainly is a strong case for it. There's some take-home points I think I've gone over, so I'm going to push on, because this can all be looked at and published, put on a we can circulate this later. And there's my references.
Thank you, Hannah.
Sorry,
does anyone want to come in with any questions at this point? I haven't got any on the chat at the moment, but if anybody wants to come in. Hannah, just a quick question, and it's probably an unfair one, but there's a lot of talk about these progesterones, but also the topical versus the systemic treatments for HRT. Is there any evidence of any benefit of one over the other?
Well, certainly the transdermal estrogen for women that have migraine or have VTE risk, they previously had a greater risk with the oral preparations. That's not the case with the transdermal preparations, because it bypasses first pass metabolism. So you don't get that change in the clotting cascade and the thrombin production. So they're safe in women with migraine and with VTE risk.
Okay.
There isn't.
Okay. So what we'll do is, if there aren't any questions on that at the moment, we'll move on to Joe. And if anyone wants some questions, and perhaps if we bring it all together towards the end, please put your hand up and give us a shout. Joe, would you like to take over? So Joe is our advanced nurse practitioner, very experienced breast clinician, and she has been with us, I don't know, about 2 or 3 years now, but previously done the similar role elsewhere, and has set up our patient-triggered follow-up program, which includes giving patients advice on how to manage some of these menopausal symptoms after breast cancer treatment. Joe, are you there? Oh, we lost her. Oh no, we can't hear you.
Can you hear me now?
Yes, we can. That's lovely. Thank
you. Can you see my screen?
I can't see your screen. I can see you.
Okay, let me try and share.
That's it. You're sharing.
And am I sharing my presentation?
No, you're sharing your emails. Oh, there, you've got it now.
Okay. Okay. So. Okay. So yeah, I'd like to present this with Claire as well. Claire's one of our long-standing, again, very experienced, knowledgeable CNSs working at HRT Breast Unit, and she's here with us. If you like to give a wave. So
we've got speaker view on, so I've only got you,
okay,
Joe. But sorry, Claire, I hadn't spotted you there.
So we've got 10 minutes to cover a really wide area. So it is a whistle-stop tour through this, and a lot of you listening will have huge experience. So I'm hoping you'll chip in. This should be something you feel you can add to, but we'll go through and see how we get on. So what we'll be looking at in this 10 minutes is just a little bit of background to the cause of menopausal symptoms in women treated for breast cancer, the significance and some of the mechanisms, the management of the main symptoms of menopause. We're not going to be talking about HRT today, and the management in particular of hot flushes, urogenital problems, joint aches and pains, mood change, insomnia, and I've also put some resources in there which you may find helpful at the end. So the big question is, are menopausal problems in women who've had diagnosis and treatment for breast cancer any different to naturally experienced menopause? There's been a lot of research in this area which suggests that whilst menopausal symptoms for women who haven't had treatment are very prevalent, they are perhaps more prevalent in this group of women. Also, studies have highlighted that because some of the treatments, certainly in premenopausal women, are put women into a straight menopause. There's a more of an acute response. It's very dramatic, no gradual build-up. There's evidence there is increasing frequency of things like hot flushes, night sweats. The symptoms can be more intense. And of course, if treatment is going on for 10 years, it can be more prolonged. So most of the studies are suggesting about 70% of our population of women will be having menopausal symptoms, and I would say that's probably higher. And I expect Karen, who sees a lot of the follow-up, would also agree with that. Certainly anecdotally in clinic, most people do have one or more menopausal symptoms that we see. So treatment-related causes of premature menopause include chemotherapy in the premenopausal women, where there's temporary or permanent damage to the ovarian follicles, and also premature ovarian suppression that we often use. Most commonly Zoladex, but Prostap is now licensed for this use. Tamoxifen, which we use across the spectrum, not just in premenopausal women, may cause menopausal symptoms without actually stopping their ovarian function. And the other hormone therapies we use, the aromatase inhibitors, can cause a resumption of the menopausal symptoms long time after menopause is experienced because of the dramatic reduction in estrogen levels. This presentation, in fact, is one that I use for women coming on moving forward, and I've just adapted it slightly. So we've got two slides here about how the different drugs work. I did think this might be useful for people who need to explain the differences to women of how tamoxifen works very differently to aromatase inhibitors, as that can give them some understanding as to what's going on in the body. So yeah, I'll just go past these slides here. These are just some of the symptoms experienced. So we're going to be focusing, as I say, on hot flushes. We're going to look at the urogenital symptoms and the joint aches in particular. Most of you probably know what the mechanism is in a hot flush. We think it's related to the reduction in estrogen supersensitizing the temperature regulating center in the brain. So the thermoneutral zone becomes smaller, and so this triggers the hot flush and the night sweat much easier than in someone that's not gone through menopause. We're going to just go through some of the non-drug strategies now that we recommend to our women, and most of you are probably familiar with these. When me and Claire were discussing this, we did say that one of the most important things is helping women to self-manage. If they feel they can self-manage, they will feel that their symptoms they can live with their symptoms much easier. So it's about giving the patient that control and helping them explore all the options that are available to them. Sometimes it's as simple as suggesting they change the time of day they take their medication. If people are getting a lot of night sweats, taking it in the morning can help, and vice versa. Splitting the dose, so taking, for example, tamoxifen 10 in the morning, 10 at night. Sometimes it's just simply recommending a change in treatment. We know that cross-sectional studies have shown that hot flushes are experienced just slightly more often than in women taking tamoxifen than aromatase inhibitors. So if that's the prime problem and a woman's post-menopausal, we can look at switching them over to an aromatase inhibitor, and that might be all that's needed. Exercise, gentle, regular aerobic exercise, there is some evidence for, and again, it gives women back that control and can help reduce BMI. The things below are just about reducing core body temperature and avoiding triggers. And there's lots of things we could add to that as well. We do often recommend the Chillo Pillow, peppermint oil sprays, and yeah, identifying the triggers and avoiding those. We can add to this later when we discuss if people have got anything in particular they found helpful. So the natural therapies, these are lots of things that women will ask us, are they worth taking in clinic? Again, it is a matter of control and choice. There is limited or no evidence that any of these actually have a beneficial effect on hot flushes, and we do have to be careful when recommending certain products like black cohosh because of the potential side effects. So the other thing to say with products such as red clover, they are very, very concentrated form of phytoestrogen. So if I just go to the next slide, so phytoestrogens in the diet, you may often get asked, is it safe to take these? And I would urge you to have a look at the World Cancer Research Fund website if you haven't already, because there is some very high level evidence there about diet, and some very longitudinal observational studies looking at diet. And this seems to suggest that phytoestrogens are safe as far as we can establish. But when it comes to very concentrated forms in tablets, we don't know, and they're certainly not tested. There's no research to say one way or the other. So what we would signpost people to the World Cancer Research Fund, because the evidence does change all the time, although we're always looking at it. But the evidence to date suggests these are safe. And obviously all these things are pretty healthy. Complementary therapies, many are not yet supported by the scientific evidence, some are. So there are, if we go down to CBT at the bottom there, there's a whole range of studies called the MENOS-4 studies, which have been done by a psychotherapist and her team, suggesting that CBT can help women with hot flushes by, again, giving them that control and helping them to live with hot flush and night sweats, not necessarily reducing them, but helping women to live and feel that they can manage them themselves. There are one or two very small studies looking at hypnosis and breathing and relaxation. There is one study supporting its use, but again, that has to be taught properly for it to be effective. So the drug treatments that don't involve HRT, hopefully most of you are familiar with these. The most evidence surrounds use of the SSRIs and SNRIs, particularly venlafaxine. We have a policy in the unit that we use citalopram usually as our first line treatment, just based on the side effect profile. And hot flushes, the studies on SNRIs and SSRIs suggest that they can reduce the incidence and frequency by about 50%. This figure is about the same for clonidine and gabapentin, but we tend to find there are more side effects experienced by the other two drugs. However, some people will feel they want to avoid antidepressants. They feel that there's a stigma, or they've just had a bad experience before, and then we do then suggest trying clonidine. The usual dose is starting at 50 micrograms twice a day. Obviously, we check they haven't got a very low blood pressure before we start them on that. Gabapentin, because it's a multi-daily dose, the side effects tend to limit its effectiveness, but it can also be used for people who have tried everything else. And we can try a combination of those as well. So urinary and vaginal symptoms, these are just, again, there's a whole host of issues that can be experienced. These will be are more likely to be experienced by women on the aromatase inhibitors because of the absolute reduction in estrogen levels, but they can be experienced by women on tamoxifen as well. Women on tamoxifen are more likely to get an increase in their vaginal discharge and are probably more likely to get thrush-like symptoms. whereas women on the AIs report more often the thinning of the vaginal lining, bleeding, and some of the other symptoms we have here, decreased libido being one of those. So in terms of what we recommend, the first thing is establishing, and a lot of the time women will have these and they won't volunteer the information in clinic. So I think it's a very under-reported problem. So often if we do actually ask women, they will say, well, yes, I am having this symptom, and then it's something that we can easily help with. We do recommend in a stepwise approach. So we usually recommend the vaginal moisturizers and the lubricants first. We do also recommend that they see if these can be obtained on prescription. We have some samples that we can give out in clinic, but we do ask them to go to their GP to see if they are available. Some women are happy to buy them, but some who can't afford to buy them, we feel that it should be available on prescription for them. We tend to recommend the Yes products just because we have a wide range of products, and there's been some research looking at the effect of these. And there are different ones which I'm sure you're all familiar with, but we can talk about them further later if necessary. If these don't help, then we're on to topical estrogens, and I think this is one area that people have differing feelings on. We have some advice and guidance on our on the HHFT website, which we've signposted you to about this, but generally speaking, if people have tried the other options, we're happy for them to use a short course of Vagifem or other, starting with a daily dose over 2 weeks and then down to twice weekly for about 6 weeks, then coming off and then going back on. So the evidence around this, I've got a whole list of research papers on the next page, which you can have a delve into if you like. There isn't any evidence that these increase the risk of breast cancer, but I think there's not really been that depth of research looking longitudinally at women. That a lot of the studies are small samples. There's been 1 or 2 studies looking at the local absorption rates. One found the estrogen levels did go up to about 70, which is sort of the normal postmenopausal range, but then went back down again. It doesn't seem to be sustained over the longer term. So women who are on tamoxifen, however, the theory is that this will be blocked, and so there is less worry about taking about using estrogen vaginally in these women. We then have the option of referring to psychosexual counselling at Southampton. This service is there, it's there for GPs to refer to, and again I've got that at the end of the presentation. There's the referral there if people aren't aware of it, that they can look at. The service is very happy to come and talk to people as well if they don't have that awareness of what the service can provide. But this can be really helpful, a more holistic way of looking at the issue, as it's not usually just down to physical issues, but the whole, the whole thing of diagnosis, the change in body image and the lack of estrogen that can affect a woman. So these are just some of the references here if people are interested. Sorry, I meant to take that slide out because we're talking about that next time. So I'm going to skip over that. Joint pain and stiffness. About 50% of women on aromatase inhibitors will experience joint pain and stiffness. It seems to be more prevalent than in women going through menopause generally. It's usually experienced in the hands and feet are the most commonly affected joints, and it's usually symmetrical. Obviously, there's that worry about missing things in a woman previously diagnosed with breast cancer, but the pattern is usually quite different from bone metastases, although we are always very careful to exclude that. The typical thing is it comes on 6 to 8 weeks after they start treatment. It peaks about 6 months, and it can about 20% of women want to stop their medication because of this side effect. It can be really severe and disabling. These are the treatments that we can suggest. There's a lot of research around the use of acupuncture, lots and lots of studies. It seems to be helpful. Of course, accessing acupuncture can be difficult. We used to refer people to the Haven, and unfortunately they've had to close during COVID. Hopefully some of the GPs will have access to acupuncture, and of course there are private therapists around as well. Switching therapy can be a useful tactic. Certainly switching to tamoxifen. Joint pains and stiffness can be experienced by women on tamoxifen, but to a much lesser degree. So that's often a really good strategy. Exercise, there are a few research studies looking at exercise, suggesting this can be beneficial, and certainly it enables women to feel their confidence is improved because they can exercise without increasing their joint pain and stiffness. And there's been a few studies looking at omega-3 with mixed results. Hormonal changes can also cause psychological symptoms, of course, and mood change. Anxiety is a big risk factor during menopause, and we see this a lot. And obviously, again, this is compounded with the diagnosis of breast cancer, changes in body image, and so on. We obviously have lots of resources here that we can talk to them about. We do signpost them back to their GP as well, because we know that they are the long-term care and may know that person really well. But certainly if we can help, we would always encourage people to contact us. And these are just some of the resources here. We do usually recommend a combination of some medication if people are willing, and talking therapy. And insomnia can go hand in hand with that. And these are just some of the things we would discuss with them. So just in summary, here are some of the resources that you may find helpful. The HHFT breast unit advice and guidance, some of the things we've discussed are there for you to have a look at. Please do contact us. If you're having any issues, we'll always be happy to advise. Breast Cancer Now, previously Breast Cancer Care, have really good resources for patients, forums, support groups, and the Becker app can be downloaded on their smartphone. The psychosexual counselling service, the referral guidance is just here. These are some of the nice guidance that have the recommendations that you can dip into, and then Newson's statement on genitourinary symptom in menopause is helpful there, and it talks a little bit about testosterone, which I haven't talked about actually, but we can maybe discuss after all the presentations. Claire, I don't know if you have anything to add that I've missed.
Hi, I think that was a fabulous presentation, Jo. Thank you. I think the only thing I would possibly add was the benefit in well-being with using therapies and the support that women get from talking to each other. I think that is second to none. This menopause support groups and also peer support through the Moving Forward programme, which has sadly gone online during COVID times, but we're hoping to bring back face-to-face, where patients can support each other with side effects and symptoms and benefits that they've found with things like complementary therapies and massage and alternative treatments. Thanks, Jo.
Can I open up to any other questions? Has anybody got any questions or comments they want to come in on?
Yeah, Jo, I had a tricky one the other day. Lady on tamoxifen who wanted to take HRT whilst taking tamoxifen.
I can come on to some of that in a minute. But it's interesting, that one. But I mean, the main thing is we don't really know what the VTE risk is, because both of them have got an increased, albeit small, but what is the combined VTE risk, and that would be my concern with those two. But I'll come back to that one in a minute. Joe Bonser, you came off mute there for a minute. I just spotted. Did you do that?
Hello.
Or yeah, you look like you came off mute.
Might have been a mistake.
Oh right. Okay.
No, I'm interested to hear a bit more about what Hannah asked. So thank you very much for the presentations. I guess I'm thinking about, you know, when we've tried all of the things that, you know, the sort of non-HRT measures, I guess that, you know, the question that I'm sort of wondering about is, you know, it's very difficult, isn't it? You know, but if someone's coming to you and they're, you know, suicidal, you know, everything's a complete nightmare, I don't care if I get recurrence of my breast cancer type situation, you know, I'm just wondering, you know, where you know, what your that's really why I'm just really interested to know what your feelings are and what your thoughts are.
So I think that leads very nicely into my talk. So if you don't mind, I will just give a summary, and then perhaps we can wash up with the discussion and go in from there. It just sort of seems to follow quite nicely. Let me see if I can get to. Can you see the actual presentation rather than? I can't see what you're seeing at the moment, so doesn't seem to want to present itself for some reason. Oh, there we go. Right, does that look all right? Okay, thank you. So just talking about use of HRT after breast cancer, and I think the main thing, just to sort of remind ourselves, is we all know that breast cancer is hormonally driven. So we know that if you've got excess estrogen, either because you have an early menarche or late menopause, you have very small risk, but there is an increased risk with HRT. We know that, for example, excess estrogen associated with obesity increases the risk of breast cancer in both men and in women. And men with gynecomastia, by definition, got too much estrogen floating around, they are more likely to get breast cancer than men without gynecomastia. So we know that estrogen is definitely a driver of breast cancer, even if it's not necessarily a cause in its own right. And we also know that estrogen blockade treats breast cancer, and we've known that since the 1800s. So, you know, this is a sort of, this is where it becomes uncomfortable, because it's very much, the science says, estrogen treats breast cancer, estrogen blockade treats breast cancer, and estrogen, you know, increases the risk. So there have been some studies that have looked at giving HRT after breast cancer, and these are the ones that are frequently quoted by the British Menopause Society and others. And you have to go into quite a lot of detail to actually look at where the issues come, because the two there were actually four randomized control trials three randomized control trials looking at giving HRT after breast cancer, and the one with Tibolone, which was thought to be was going to be the Great White Hope, that was closed because there was a hazard ratio increased risk of breast cancer relapse. And the two other studies, the Stockholm study and the Habit study, they both closed early. And what's really interesting about some of these things is that there's been lots of quotes about these shouldn't have been closed early, and that the long-term follow-up doesn't show the same increased risk. But when you delve deep into it, a lot of these patients were also taking HRT as well as the tamoxifen as well as the HRT, and so you can't just say stop your tamoxifen, start the HRT, and we know it's going to be safe, because even these studies that are proving controversial in the long term don't necessarily support that. And The other thing that the Menopause Society really promotes is that HRT after breast cancer cohort studies, and these have not showed an increased risk in relapse. And most of these studies are not good quality, but the one good quality study is quite interesting, because there were some little biases in the selection. For example, there were more women in that study who, it was a good study, but there were more women in that study who had HRT, who'd had a mastectomy, than in those who didn't have the HRT. And we do know that you have a slight increased risk in local relapse with breast preservation, and that could account for that in that study. So there are lots of reasons why these studies don't give us a clear cut answer, but the overall outcome is that the difference is likely to be relatively small. And there is a suggestion that if you can suppress estrogen for at least 2 years after the diagnosis, then restarting a HRT after that may not be so dangerous, because obviously the peak of relapse is 2 to 3 years. If we haven't seen a relapse at that point, there shouldn't be any occult metastatic disease, and this might be the time. This might be the time that it's safe to go for the HRT. So if somebody is struggling, if they can get to the 2 years, then that could well be quite useful for looking at risk. This was the good cohort study. They looked at 174 ladies on HRT, and they had a large database, and they picked out 694 cases with similar characteristics. The follow-up was relatively short, but not bad. They had HRT for at least 6 months, but the average duration was only 15 months. So it wasn't going to the 5 years or maybe even the 10 years that we might be talking about. That study also looked at vaginal estrogens only, and this was using the American dose of vaginal estrogens, which is a lot higher than the normal dose we give in the UK. And just to remind people that all the alerts about vaginal estrogen and breast cancer relapse risk are associated with this much higher dose that's given in the American series, and not anything to do with the standard UK doses. There was slight difference in these different rates, so the groups weren't exactly matched, and some of these differences may account for the difference in the fact that we didn't see a difference in relapse. And then we also, when we want to look at, is it safe to take HRT, we need to look a little bit at what the actual the nature of that particular individual's breast cancer. So when a patient has a estrogen receptor positive tumor, we know that treating them with estrogen blockers is going to reduce their relapse, and therefore giving back the estrogen, especially in the early days, is likely to increase the risk of relapse, albeit to a small amount. But that risk really depends on both the tumor biology and the stage of the tumor. So if we've got a node positive grade 3 cancer, much more likely to relapse, and much more likely to relapse as metastatic disease than a grade 1 node negative screen detected cancer, which is much more likely to relapse in the breast, and that isn't going to have an impact on overall survival. And they do talk about up to 8% of women having metastatic disease, which is occult at presentation, that is treated by the systemic therapy that we give. For women whose tumours are estrogen negative, we know that an estrogen-rich environment increases the risk of a second primary breast cancer, and that it may favour a selection of a estrogen-positive clone. So it's not 100% safe to give estrogen just because the original cancer was estrogen negative. Again, the risk should be smaller. I think, Joe basically touched on this. The SERMs, tamoxifen, raloxifene, that sort of drug, they stop estrogen from working at a cellular level. They block any exogenous, for example, vaginal estrogens that get into the circulation, but they can be associated with a slight thrombotic risk. But patients that are treated with aromatase inhibitors, those are estrogen negative and that have had an oophorectomy, that's the only treatment without tamoxifen, estrogen isn't being produced. And so any added estrogen will circulate and it will have an effect, albeit possibly small. What I would say is that there's absolutely no point in prescribing an aromatase inhibitor and systemic HRT. The two are mutually exclusive, and you either decide to stop the aromatase inhibitor and see how you get on, or you stop the aromatase inhibitor and then add in HRT. You don't give the two of them together, complete waste of prescription. There is a potential increased risk of thrombosis with tamoxifen and HRT. We haven't seen any particular quantification of that risk. And as I say, up to 50% of people in the Scandinavian studies did have co-prescription. So that is a possibility. And again, you'd have to be careful with people with an intact uterus. You'd have to make sure that the progesterones were part of that prescription. I added Mirena in here. We often get a lot of perimenopausal women who've still got a Mirena in. It's coming to the end of its days, but it's still functioning. Absolutely no problem with keeping that Mirena in, as far as we can tell, when patients are on tamoxifen, because anything absorbed either by the vaginal estrogens or from the progesterone in the Mirena should be counteracted by the tamoxifen where it matters. All sorts of cautions out there, but there's certainly no significant evidence that this is a problem in this sort of patient. But again, caution needs to be taken if patients are on an aromatase inhibitor. But vaginal estrogens we very much support at the standard UK doses. When we see a patient who wants to talk about coming off the tablets because they're having side effects with them, we tend to do a risk assessment with them. What is their risk from their breast cancer coming back, causing metastatic disease and causing them to die as a result of breast cancer? And this tool, which is NHS Predict, is really useful. And we get an infographic similar to the one on the display, to just put into context where they are. And as a guesstimate, I tell them that the HRT makes it go the other way. So the 2 extra survivors due to hormone therapy, that will go, and the see-through orange ones here, so they'll go up from 2 to 4. And so that's roughly where we're going. And the local relapse risk is around about 1% a year. It peaks at 2 to 3 years, and it doesn't always have an impact on life expectancy and good prognosis tumours. So again, I'm not quite so I can be quite blasé about local regional recurrence. Obviously, it can be quite devastating for the patients, but if it's something that they're prepared to accept, has got the same impact on life expectancy. So we talk about the risk of the relapse, and we also talk about the timings, because a lot of patients say to me, "Oh, I don't mind relapsing. I'll be 70 in 10 years' time." Well, the relapse might come in 2 years' time, and you haven't had your holiday of your lifetime, and you've gone off in your motorhome around Europe or whatever. So it's I have to explain to people when the problems are likely to come, rather than them assuming that they're not going to come for decades. We talk about the level of risk reduction with the endocrine therapy, and then I would suggest that they stop the endocrine therapy first, see if their symptoms resolve or improve enough not to need to take the HRT, and to try the non-hormonal treatments that Joe went through. It's really important that we get patients engaged in looking at their health overall in a more holistic way, and looking at the, for example, the effect of weight loss and exercise. We know that being slimmer and losing weight will reduce the intensity and the significance of flushes. It also reduces breast cancer recurrence. So there is a big drive to really push that agenda, get those patients exercising, get them to have a healthy diet. I've got a bee in my bonnet that I think that flushes are related to gut health. So again, having a healthy diet, there's no proof for that, by the way, so don't quote me. But having a nice healthy diet, eating all the sensible things is really going to help. And I just wonder sometimes where we seem to prescribe HRT and then we stop HRT, and actually what we should really be doing is seeing if weaning helps, because you don't want to just put off the problems for 5 years. You want to be able to say to someone, right, we're going to get your body used to having lower levels of estrogen. It's not going to make any difference to the cancer risk, and we're not talking about it from that point of view, but it's just a way of not giving them the same problems in 5 years' time. And therefore, just to summarise, the data on HRT after breast cancer is really conflicting, because the quality of the studies hasn't allowed us to get a definitive answer. Estrogen supplementation is likely to increase breast cancer relapse, but it may not have a significant impact on overall survival in the majority of patients. Myarinas and vaginal estrogens are safe, particularly with tamoxifen, but as long as the patient is warned when they're on an AI, it still may be useful, as again, as Joe outlined earlier on. We're very much the quality of life matters. So we're not a unit that says you must stop HRT, you must never take it, it's evil. It's all about discussion of risks, looking at the alternatives. And we are prescribing HRT for symptom control. It's not, we're not recommending that it's prescribed for preventing heart disease and osteoporosis. We obviously have alternatives for that, even if it is beneficial in outside of the context of breast cancer. That wouldn't be something that we would agree with in the context of a breast cancer. And don't mix any hormonal preparations with AIs. It's a waste of time. Thank you. Can I open to more questions? Did I answer your question, Joe? You're still on mute.
Hi, sorry, that was brilliant. Thank you so much. Yeah, really helpful. One question I've got, when you were talking about for the women who are very anxious about using vaginal estrogens, despite the GSM joint statement, the thing you mentioned about the 2-year systemic waiting period before HRT. Would you talk about that at all with the vaginal estrogens, or
No, I mean, I think the general consensus is that we're not so anxious about vaginal estrogens. Yes, limit the dose so that you're not over generous with it. You want to make sure that it's working, but they're not. Perhaps they don't have the. I'm trying to think of a polite way to put this, but they don't have the vaginal lining of a 20-year-old. It's about being appropriate for controlling the symptoms that they've got. But no, I would, because we wouldn't feel you can't have it. I spotted Karen getting. I don't know if Karen wants to pop in, because obviously she's got some strong views on these things, but. One of the things that's really difficult with all of this is we're all becoming so super specialized that you do get very focused on what your where your niche is. And so, for example, where Karen's coming from, all her discussions with patients are about reducing risk of getting breast cancer in the first place and what you can do to avoid that. And a lot of that is, well, you've got to be careful about what contraception you choose, how long you take hormonal contraception for, etc., whether you take HRT or not. And it's really difficult to move from that conversation when you're talking about small reductions in risk to then say, oh, you've got breast cancer, but we don't mind you having your HRT, because the risk isn't that much. It's really about getting that balance right between those conversations. Don't know if she's disappeared.
I think I do
see.
try.
Oh, there you are. Yeah.
But no, I mean, the only thing I'd say is really, before I kind of go down the pathway of really, do you need vaginal estrogens? I think it makes a massive difference, honestly, if women just moisturize with ordinary things like E45, Epiderm. I've had several patients, they're just really happy with that. They don't need to go on to vaginal estrogens. And so it's a really safe alternative and much more effective than the expensive vaginal moisturizers that you can prescribe. So, you know, that's my first line. And then I move on to them, obviously. I think no problem with tamoxifen. With the aromatase inhibitors, I think you've just got to have a word of caution, because we don't have evidence either way. But you know, I just think, well, theoretically there's a small risk, but really nobody's bothered. But as long as it's not continuous, and you know that they understand that they are taking a small risk, I think that the bottom line of all of this is about them calculating the fact that they're making a decision, and it's not you, the GP, who is, you know, advising. I think you're in a very difficult position. And I think with this one about the tamoxifen and the HRT, I really wouldn't think in general practice you should be in the position of answering that, because you've only got 10 minutes. We would do the predict score with a woman and take it step by step. You know, I wouldn't want you to think, oh, I've got to decide whether to put her on HRT and tamoxifen at the same time. I think that really is for us to sort of have a chat with her, because we've got all the details about the type of cancer she had and all that sort of stuff. But I think it's useful that you know it's possible. I just don't think it should be treated lightly, because I think, you know, although there is a lot of information, it's all observational, mostly observational studies. You know, actually, you know, you talk about risk and perspective, but actually, you know, I don't think that we can say categorically that HRT does benefit women tremendously in the cardiovascular or the osteoporotic route. There is some evidence. In fact, the Guardian today was saying HRT probably doesn't cause dementia. Well, you know, on the other websites, you'd be thinking that, oh, if I take HRT, I'm not going to fracture my hips, I'm not going to get dementia, I'm not going to have a heart attack. Well, I'm not sure it's as clear cut as that. And I'm not sure the risks and benefits are being actually really chewed through. I feel like a little bit like some bits are being overlooked and other bits, there's a bit of cherry picking going on, which I'm not quite so happy about, but it doesn't really matter, I suppose, in the normal population, because as we said, the risks are small. But I think the problem for me is that I'm seeing, really, it's a bit naive in a way to just sort of say that women in the population are not at risk, because we're learning what the risks are now. We're knowing about density of breast, we know about previous biopsies that they may have had. We're looking at this thing called CAN risk, where basically if you don't have your baby till you're over 32 years of age, and then you go and have a grandmother who's had breast cancer, that actually puts you in a moderate risk group category. So, you know, as this information becomes clearer, we'll probably be able to really guide women a bit more realistically. I think at the moment it's a bit too easy just to say, yeah, everybody should take HRT. And I kind of want to stay her off that bandwagon, because I think women should look at alternatives, looking at their health, exercise. I think one of the problems is it's all right saying it's a very low risk, but you know, you've got a woman there who's probably smoking and drinking 3 bottles of wine a week and telling you she wants to be on HRT. You know, and I think that's the problem. It's not just about the HRT, is it, at the end of the day? That's my little bit, sorry.
I totally agree. I think it's around about having that conversation about balancing the risk and accepting the risks and looking at the patient in a holistic way. And we're really lucky in our unit that we have got people who've got they come from different backgrounds, so we can look at patients with a different eye. And share that, so we're not just simply looking at with a single issue. I've realised that we're just over time, and I just wondered whether anybody wanted to add anything else before we wrap up for today.
Could I just say about tamoxifen?
Yeah.
It was just a little thing. Just if you're gonna prescribe antidepressants, just choose citalopram, like Joe said, or sertraline. Try and steer away from fluoxetine or paroxetine because they interfere with the metabolism of tamoxifen. That's all. But you don't need to worry about aromatase inhibitors. It's just with the tamoxifen. That was all.
Okay, can I just wrap up then and thank everybody for their time. I will put the recording onto YouTube, so if people want to get to it, they can search for it under my name. I haven't been any more organised than that. And we have another webinar where we're talking about bone health and chemoprophylaxis. Is that right, Karen?
Yeah.
In a couple of weeks' time, and then I'll get the subsequent webinars organised after that. But thank you very much indeed. Thank you for your time.